Hello, everyone. Welcome to today's webinar hosted by the International Society on Thrombosis and Haemostasis World Thrombosis Day campaign. We are happy to have you join us today for an information-packed session. Today's webinar is on venous thromboembolism, or VTE, burden of disease, and prophylactic considerations. Specifically, we will be looking at VTE care and prevention with a detailed focus in the Asia-Pacific region. I am Dr. Jameela Sathar, and I'm delighted to be with you today as our moderator. I currently serve as a consultant hematologist at Ampang Hospital in Malaysia, where I care for patients with thalassemia, hemophilia, thrombosis, and bleeding disorders. For today's webinar, we have brought together a very special lineup of leading thrombosis experts from across Asia Pacific to bring the latest information and research to you. Our presenters today include Dr. Lee Lai Heng from Singapore, Dr. Pantep Angchaisuksiri from Thailand, and Dr. Christopher Ward from Australia. We are also joined by two panelists who will participate in the question and answer session later in the webinar, including Dr. Hu Yu from China and Dr. Eriko from Japan. Thank you to all of you, to all our speakers for being here today. Before we get started, I would like to take a moment to review a few technical matters and let you know how you can participate in today's session. We would like today's webinar to be interactive, and as such, we encourage you to submit questions using the Q&A option available here in the webinar portal. We'll be monitoring questions and will address as many questions as we can during the Q&A session at the conclusion of the webinar. We have set aside 30 minutes for the Q&A, so we hope to get to as many of your questions as we can. Please note that today's webinar will be recorded. We will share a copy of the recording via email following the conclusion of the webinar. We welcome you to share it with your colleagues. So, okay, why don't we get started? Are you all ready? I am pleased to introduce our first speaker, Dr. Lee Lai Heng from Singapore. Dr. Lee Lai Heng is a senior consultant with the Department of Hematology at Singapore General Hospital. She is a member of the World Thrombosis Day Steering Committee and helped lead the development of today's webinar. And you should give her applause. She serves in many leadership roles within the field, including the Asia Pacific Society of Thrombosis and Haemostasis and the Singapore Society of Hematology. Welcome, Dr. Lee. Okay.
Thank you for the kind introduction, Jameela. I'm pleased today to share on the venous thromboembolism in Asia on its epidemiology and risk factors. I can't forward the slide. Can you forward the slide for me? Yeah, these are my disclosures. Next slide, please. There has been a long-standing notion that venous thromboembolism is very rare in Asia. And a long time ago in 1964, Dr. Tinkler from Singapore General Hospital reported in the British British Medical Journal on the apparent non-occurrence of post-operative deep vein thrombosis and pulmonary embolism. A few years later, this was echoed by another publication, also coming from Singapore, on the rarity of pulmonary embolism, where it reported that the post-operative fatal PE in Asians is less than 1/10 of that reported in the West. Next, please. And now, about half a century later, next slide, that we still see publications of the low rates of VTE in Asians outside Asia. From America, in San Diego, this San Diego population study reported the rate of DVT in Asia about a quarter of that of the whites. And in a California study, they reported a very low rates of VTE in Asian at about 70, as low as 70, less than 70% of that in the West. Okay. But however, in Asia, we see a rising trend of VTE in our hospitals. The red bars denote the figures from Singapore, where in 1992, we see a 7.7 per 10,000 hospital admissions at the National University. And this quickly rose to 19.3 in the 1967 and 1997, in Singapore General Hospital. And then as we cross into the early 2000s, we see a spike of VTE at 45.3 per 10,000. And we are not alone in seeing this rise in VTE in the hospitals. All across Asia, we also see a similar rise. Okay, with about 3 per 10,000 admissions in Hong Kong and KL in the late 80s, early 90s, going to around 20s, in the mid 1990s, and then quickly going on to about 50 per 10,000 admissions as we cross into the millennium. So with this rise that we see, in the hospital, we have to have a change of mindset as how we view VTE. From a rare, insignificant disease, it has morphed into a disease that cannot be ignored. But there are many differing views, on the treatment and prophylaxis strategies of VTE. And to address these differing views, we need to understand DVT and PE in the Asia Pacific. With regards to its population burden, we need to understand the risk factors particular to this region and need to know the natural history and outcomes locally. So a more recent systematic review, on population-based estimates of incidence of VTE in Asia, we see that in Korea was reported to be at 8.83 per 100,000 population in 2004 and rising to 13.8. And in Taiwan and Hong Kong, it was reported to be around 16 and 21 per 100,000 in the early 2000s. But these rates are like 15 to 20%, of what is reported in the Western countries, which reported approximately 100 per 100,000 people. So we do see a lower population rates of VTE as reported some 10 years ago. However, if you look closely at this data, it is clear that there is a rising trend, of the population VTE incidence. So in South Korea, we see that in 2004 is 8.83, rising to 13.8 in 2008, and then rising subsequently every year to hit 29.2 per 100,000 population. And each rise is significant when compared to previous years. So I'm not surprised that today we had even higher rates. So in Hong Kong, we see similar rates, in 2004, the risk of DVT like 17.1 rising to 30 in 2018, with a corresponding rise in pulmonary embolism at 3.9 per 100,000 to 11.7 per 100,000. So why do we see these rates? We are also curious to find the reasons, underlying these increasing rates of DVT. And one of them could be an increased awareness leading to increased diagnosis. And this is very elegantly shown in this study coming from a obstetric department in Hong Kong. So between 1998 to December 2000, there were 32 women diagnosed with VTE in that department, of which one died. And after the patient died, there was a spike in the request of ultrasound to exclude DVT. Like before, the maternal death is at 1.6 per 1,000 deliveries, spiking 7 times, to 10.7 per 1,000 deliveries. And with this spike in rates of ultrasound requests, we see a 10-fold increase in the number of DVT diagnosed from 0.29 to 2.9 per 1,000 deliveries. And with that, they calculated the incidence of pregnancy-associated DVT to be 1.88 per 1,000 deliveries. And this compares well with the Western data, which ranges from 0.6 to 1.3 episodes per 1,000 deliveries. As we move across to China, we also see a nationwide program to increase awareness and availability of diagnostic tools. And with this program, again, we see the increase in the reported prevalence of pulmonary embolism. Okay, from 1997, 0% to 0.1% in 2003. Okay, and the good thing is that the case fertility has decreased from 25.1% in 97 to 8.6% in 2008. And we think that that's because with the cases being diagnosed, timely and appropriate treatment can be given to these patients, and then we see a drop in mortality rates due to PE. Okay, however, even at the peak of prevalence at 0.1% in the Chinese hospitals, it is still lower than the 0.3 to 0.4% we see in large teaching hospitals in the USA. So what are the risk factors that we have in Asia? We see in that the advancing age is a very strong risk factors. In South Korea, okay, we see that there is a spike in the prevalence in patients, okay, above 40 years old, such that in patients at ages 60s, 70s, and 80s, okay, have a 6 times, 12 times, and 15 times increased risk compared to those in their 30s in the period 2004 to 2008. And moving forward from 2009 to 2013, the risk, okay, in this same age groups have increased to 10 times, 22 times, and 29 times. So increasing age certainly is a risk factor. And we see in Taiwan and Hong Kong, similarly, that after 40 years of age, there's a sharp rise in the rates of DVT. Okay, and with silver tsunami happening in Asia and our aging population, okay, we can expect a sharp rise in the DVT as well. Okay, this is that. Okay, moving on to inherited thrombophilia in Asian studies, okay, we see that there's a vast difference, in the type of thrombophilia we see across different races and ethnic groups, right? Like in the factor 5, in the patients who had developed DVT, we see 20% of factor 5 Leiden and 6% of prothrombin gene mutation positive in the Caucasian populations, okay, but none, okay, in the Asian populations. Yet in the Asian populations, in the Thai, Chinese, Japanese, we have seen much larger proportion, okay, of the deficiency in natural anticoagulant, such as protein C, protein S, and antithrombin. Okay, and similarly, we see that there is a very low rates of these deficiencies in the Caucasian populations. So for the population prevalence, we don't have much data in Asian countries, but for the Caucasian populations, we see that in the population, they have like 2 to 5% of factor 5 Leiden and prothrombin gene mutation for the heterozygous states. And again, for the antithrombin, protein C, and S deficiency, is all reported to be less than 1%. However, the relative risk, of this deficiency in the natural anticoagulants is a lot higher, reported to be like 50, 15, and 10 times risk for antithrombin, protein C, and protein S deficiency, as compared to factor 5 Leiden and prothrombin gene mutation is like 3 to 4 times respectively. So in Asia, although we don't have the factor 5 Leiden prothrombin gene mutation, the inherited thrombophilia that we have are a lot more thrombogenic than factor 5 Leiden and prothrombin gene mutation. And the other comorbidities besides inherited thrombophilias and old age that we see here in Asia are that of cancer, previous DVT, immobility, acute or chronic heart and lung conditions, stroke or paralysis, and a whole lot of inflammatory disorders such as the SLE, the dermatomyositis, rheumatoid arthritis, and so forth. And in Asia, obesity is associated with increased risk of VTE. And our obesity here is defined as 25 kilogram per meter square. Interestingly, in Taiwan, 27% has no recorded predisposition. So apart from old age, cancer is really our most important acquired cause or acquired underlying factor for development of VTE. Now, in this pandemic climate, we want to mention a few words on the venous thromboembolism in COVID patients. In the earlier studies coming out from Europe, okay, in the early months of pandemic, we see a very high rates of DVT with overall rates, okay, ranging from 30 to as high as 69%, with even higher rates in the critically ill patients. Then moving on, okay, some months later, there is a systematic review and meta-analysis of 66 studies, and we see a more realistic rate, okay, of the overall prevalence estimate of 14% with ultrasound screening and 9.5% without ultrasound screening, and that the VT prevalence of about 8% in non-ICU and 22 or 23 around 23% in the ICU settings. For pulmonary embolism, a 3.5% non-ICU setting and a 13.7% in the ICU setting. Okay. And there were calls for increased dose of prophylaxis with anticoagulant in COVID patients at that time. And as we review our own data in Singapore, we really see that we have very low rates of VTE. And even in the ICU setting, we only see like 1.8% of DVT, okay, and with higher arterial rates, but our major bleeding rate was 14.8%. So looking at our own data, we cannot endorse, the higher dose anticoagulant for prophylaxis. But in ICU, we would still practice the standard dose of prophylaxis if the patient is not at risk for bleeding. And last year, we have a bunch of interesting articles on the use of therapeutic anticoagulation with heparin in non-critically ill patients with COVID-19 for reduction of the ICU stay. In other words, they think that therapeutic anticoagulation in this group of patients can reduce the rates of disease progression, okay, and improve overall outcomes. Okay. But if you look at this data more in details, we see that the patients assigned to therapeutic doses of low molecular weight has a better composite outcome of venous thrombosis, arterial thrombosis, and death. And this better composite outcome is mainly driven by the reduction of venous and arterial events with no difference in mortality rates. And since our patients back home are documented to have much lower thrombotic rates as compared to Caucasian patients, I think that these studies will not apply to our local patients. And we really could not endorse therapeutic anticoagulation in our non-critically ill patients. And furthermore, for this rapid randomized clinical trial, we see that the subgroup analysis based on race and ethnicity showed improvement only in white patients, and there's no difference in composite outcomes in Asian patients. And indeed, there was a worse outcomes in the Black and African American patients receiving therapeutic dose of low molecular weight heparin. So now we move on to surgically associated venous thromboembolism. So this issue of venous thromboembolism surrounding major orthopedic surgery has long been a contentious issue in Asia. Right. For Western population, okay, we see it's reported at least a 36 to 84% of VTE in patients undergoing major orthopedic surgery. And this really depends on how they diagnose the DVT, okay, the modalities of imaging and so forth. But back in Asia, we see a huge range from 0 to 69%. And a lot of it overlapping really between below 30%, right? So with this overlap, okay, it's actually very hard also to analyze and compare the data, as all these different studies has a different methodology, in particular, the different methods to image the DVT and confirm the DVT. But nonetheless, we see a big overlap, and most of the ranges really fall below the lower end of what is described in the Western data. So the two most often quoted studies is that of the AIDA study and the SMART study. The AIDA study reported venographic rates of DVT, of any DVT diagnosed on venogram to be 43.2%, approximate DVT 10.8%, and any isolated DVT, even a DVT of small vein, if it's picked up by venogram, altogether they constitute 32.4%. Whereas for the SMART study, the patients diagnosed are that of the symptomatic clinically and confirmed with ultrasound. And with this, we see like a 1.2% of patients with ultrasound with symptoms and ultrasound confirmed DVT. So going into the population, we see very similar studies, very similar figures as compared to the SMART study. And from population study, I think it would be similar that it is clinically symptomatic patients that is confirmed with an ultrasound. And these figures are really very similar to the SMART study. So I would think that for our Asian populations, you know, the symptomatic DVT rates is really around about 1 to 1.2, 1.3%. So what about disease burden and outcome, right? So we know that once you have a DVT, there would be a chance of recurrence. So looking at the population-based study in Taiwan, okay, the annual crude recurrence rate is about 5%, about equal in both men and women up to 4 years. And the cumulative rates up to 4 years is 14.4%. But most of them are likely to occur in the first 12 months, okay, after the first VTE. And this is like similar to the 1-year recurrence rates reported in the West of 5.6 to 12.9%. They find that it is 3 to 4 times more likely in patients with a previous VTE or cancer compared with provoked or unprovoked VTE. And what's interesting is that the risk of a recurrence after a transiently provoked or supposedly unprovoked VTE was similar, about 5%, about 1 year, which suggests that Western guidance on treatment duration should be validated in Asia. And more work on more of such work should be conducted in different parts of Asia. Well, VTE certainly is associated with increased mortality rate in the hospitals, even though the direct cause of death may not be due to the venous thrombosis. So in Taiwan, in Hong Kong, in Japan, we all see a higher rates of mortality associated with VTE patients and pulmonary embolism. And DVT can be prevented. Okay, although we think that the DVT rates in Asia is lower than in other parts of the world, right? But then again, you know, very often we are caught by surprise and very deeply saddened by patients who drop dead after a surgery for pulmonary embolism. And these patients may be otherwise healthy and just going for a joint replacement. Okay, and we also see patients with post-thrombotic syndrome, which had previous undiagnosed DVT and untreated, you know, and we know that recurrent untreated DVTs can lead to post-thrombotic syndrome. And there's a whole list of studies that show that DVT can be prevented by the use of DOACs and a low molecular weight heparin. There are also other studies to show a lower risk of DVT with appropriate application of mechanical prophylaxis in patients at high risk of bleeding. So, I mean, although our rates are lower, I think it's not a bad idea that we adopt a zero tolerance, you know, or go towards zero rate, okay, for DVT in this part of the world. So in summary, we have low incidence in the population studies, about 10 to 20% of the West. We think that this could be due to underdiagnosis from low clinician awareness. Some people think that because our genetic thrombophilia profile are different, and we don't have a lot of genetic thrombophilia, such as the factor V Leiden prothrombin gene mutation that we see in the West. However, we see a rising trend, okay, and actually the current rate of DVT in 2020 is still is expected to be more than what we see in the systematic review of population studies. And we think it could be due to an aging population. There's increasing cancer, increased surgical procedures, increasing clinician awareness, and therefore lower threshold for diagnosis, and we're diagnosing more. Okay, it's important to remember that VTE is associated with high fertility rate, high mortality rates, and it is preventable. Okay, and finally, on the applications of whatever data we have, right? So available data should not be directly extrapolated to places with different healthcare systems and less extensive databases. And similar statistics, that we want to see from Malaysia, India, Philippines, into China, Indonesia are much needed. The recommendations for anticoagulant prophylaxis on international guidelines derive from Western data for Western populations. And the balance, of absolute risk and absolute risk may not be the same as in Asia. So the advice on anticoagulation and prophylaxis strategies in Asia really ideally should be based on local data and evidence. So in short, we still have a lot more work to be done, on our incidence, on our potential bleeding risks associated with prophylaxis. And with this, I thank you.
Great presentation, Dr. Lee. Thank you so much. Now it is my pleasure to introduce our next speaker, Dr. Pantep Angchaisuksiri from Thailand. Dr. Pantep is a professor of medicine and chief of the Haemostasis and Thrombosis unit at Ramatibodi Hospital of Mahidol University in Bangkok, Thailand. He is an adjunct associate professor of medicine at the University of North Carolina at Chapel Hill's School of Medicine and is co-director of the Bangkok International Hemophilia Training Center of the World Federation of Hemophilia. Dr. Pantep is a former World Thrombosis Day steering committee member, and he was recently elected ISTH president for the year 2024 to 2026 term. Over to you, Dr. Pantep. Congratulations on your appointment.
Thank you, Jameela. Good afternoon, everyone. Next, I will talk about the identification of patients at risk and exploration of VTE risk assessment models. Patients at risk for VTE are those with risk factors for VTE, such as patients with previous history of VTE, cancer, comorbidities, obesity, advanced age, immobilization, and hormonal use. These at-risk patients should be identified as soon as possible after admission to hospital in order to provide appropriate thromboprophylaxis. Risk factors for VTE can be classified as major or minor, and transient or persistent. Major transient risk factors are surgery, trauma, and hospitalization. Major persistent risk factors are cancer and thrombophilia. Minor transient risk factors are extended travel and estrogen therapy. And minor persistent risk factors are obesity and paralysis of spinal cord injury. VTE risk can be assessed as a group or as an individual. Group risk assessment categorizes patients into major target groups, largely based on level of risk of the operation, such as minor surgery, major surgery, and high-risk orthopedic surgery. Individual risk assessment considers each patient's individual risk factors based on operative risk, in addition to patient factors, medical history, comorbidities. Systems provide a weighted numeric stratification. Patients undergoing surgical procedures are at increased risk of VTE, especially major orthopedic surgery, such as total hip or total knee replacement. Patients undergoing abdominal surgery, in particular for cancer, are also at increased risk for VTE. The Caprini score is the most widely used risk assessment model for surgical patients. It includes several surgical and patient-specific variables: stroke less than 1 month, multiple trauma less than 1 month, major lower extremity arthroplasty, hip, pelvis, or leg fracture, acute spinal cord injury less than 1 month. Each represents 5 points. Age over 75, history of VTE, thrombophilia, and family history of VTE represent 3 points. Risk factors represent 2 points, and 1 point are as shown on the slide. Patients with Caprini score of 5 or more is classified as high risk. The estimated VTE risk in the absence of thromboprophylaxis is 6% or more. Patients with Caprini score of 3 or 4 is classified as moderate risk. The estimated VTE risk is about 3%. Patients with Caprini score of 1 or 2 is considered low risk. The estimated VTE risk is 1.5%. Patients with Caprini score of 0 is classified as very low risk. The estimated VTE risk is less than 0.5%. In addition to VTE risk assessment, we also have to assess breathing risk of each patient, which depends on the type of surgery. Major trauma, neurosurgery, thoracic, and cardiac surgery have baseline breathing risk higher than plastic, bariatric, and general abdominal surgery. Also, we need to consider patient-specific risk factors such as history of bleeding, thrombocytopenia, coagulopathy, etc. Turning now to medical patients, patients who are immobilized or have reduced mobility, patients with acute heart failure, pneumonia, or any other infectious inflammatory disorder, or stroke, are at increased risk for VTE. Risk factors for VTE in medical patients depends on the disease that the patient has and the patient factor as shown on this slide. A core team of multidisciplinary professionals involving physicians, nurses, and pharmacists is needed to ensure that the patients receive adequate thromboprophylaxis. VTE and breathing risk assessment should be implemented by using existing tools at each hospital, such as checklists or electronic health record alerts. The institution of a computer alert program has been shown to increase physicians' use of prophylaxis and markedly reduce the rates of VTE among hospitalized patients at risk. In a study published in the New England Journal of Medicine in 2005, computer program identified patients at risk for VTE. Patients were then randomized to an intervention group or a control group. In the intervention group, responsible physician received electronic alert of patients' VTE risk. In the control group, no electronic alert was used. Patients in the intervention group significantly received more thromboprophylaxis, and this resulted in decreases in VTE in the intervention group by 41% at 90 days. Now, why is risk assessment important? As we know, VTE is a multifactorial condition. Hospitalization is a key risk factor. One size does not fit all. We should evaluate thromboembolism and breathing risk and consider comorbidities and other factors contributing to those risks in an individual patient. Furthermore, VTE risk varies between individual patients and even within the same patient at different time points. For medical patients, there are two commonly used VTE risk assessment models, the Padua predictive score and the improved VTE score. VTE risk factors in the Padua predictive score are decreased mobility, thrombophilia, previous history, previous trauma or surgery within the last month, age 70 years or older, heart or respiratory failure, ischemic stroke or acute myocardial infarction, acute rheumatologic disorder, and or infection, obesity, hormonal use. VTE risk factors in the improved VTE score are previous VTE, non-thrombophilia, cancer, lower limb paralysis, immobilization, ICU stay, age over 60 years. In both models, patients with a score of 4 or more are considered a high risk of VTE, and the VTE risk is more than 4% in the high risk group. Recently, elevated D-dimer of 2 times or higher than the upper limit of normal is incorporated into the improved VTE score. These RAMs are not extensively validated for guiding decisions about thromboprophylaxis. Patients who are medically ill are also often at risk for bleeding. Bleeding risk must be carefully balanced against the risk of thrombosis in these patients. Balancing these clinical considerations can be particularly challenging within the older adult patient population, given that advanced age is a risk factor for both VTE and bleeding events. Bleeding risk factors in the improved bleed risk score are active gastric or duodenal ulcer, prior bleeding within the last 3 months, thrombocytopenia, age 85 years or older, liver failure, severe kidney failure, admission to the ICU, central venous catheter, rheumatic disease, active malignancy, and male sex. Patients with a score of 7 or more are considered high risk for bleeding. Major bleeding risk is 4.1%. This improved bleeding risk score has recently been validated in over 5,000 Chinese medical patients during hospitalization. Next slide, please. In this study, about 10% of patients have improved bleeding risk score of 7 or more. Next slide. As you can see, patients with improved bleeding risk score of 7 or more have significantly higher risk of any bleeding, the blue column, and major bleeding represented by the orange column, than patients with score less than 7. It was concluded that improved bleeding risk assessment is a simple model for estimating bleeding risk in Chinese medical patients and could be used in conjunction with VTE risk assessment models to decide prophylactic treatment for VTE. This slide shows individualized patient-level risk-adapted thromboprophylaxis in medically ill patients. Risk assessment should be done at least 2 times at admission and at discharge. Acute hospitalization is the highest risk period, and VTE risk tied to immobility based on disease severity. The risk of VTE is still elevated up to 45 days post-hospital discharge. High VTE risk patients at hospital discharge are those with improved score of 4 or more, or those with elevated D-dimer and improved score of 2 to 3, age over 75 years, history of VTE, cancer, or improved DD score of 4 or more. Recommendations for Vt prophylaxis in patients who are medically ill are shown here. In patients with low VTE risk, no prophylaxis is recommended. In patients with high bleeding risk and high VTE risk, mechanical prophylaxis is suggested. However, once bleeding risk is low, consider pharmacoprophylaxis. In patients with high VTE and low bleeding risk, pharmacoprophylaxis is recommended. Next slide, please. In the 9th edition of the American College of Chest Physicians Guidelines for the non-surgical and non-orthopedic surgical chapters, a primary shift is towards an individualized approach of risk assessing the patient's bleeding risk factors, as well as their VTE risk factors for the appropriate thromboprophylactic strategy. Next. Now, what's new in VTE risk and prevention in orthopedic surgery? Epidemiology of VTE after major orthopedic surgery is changing. Optimal choices for VTE prophylaxis in total hip, total knee arthroplasty are evolving. And while the rates of VTE may be decreasing overall, some patients, for example, patients with prior VTE, remain at increased risk. Validated risk assessment models are needed to individualize decision-making in orthopedic surgery patients. In general, moving from whole group approach to individual approach. Balancing the prevention of VTE with bleeding events presents a particular challenge as clinicians aim to reconcile the risk of two sets of adverse events, VTE and bleeding, to find a net clinical thromboprophylactic benefit. Next. Recent survey in Asia showed that only half of the clinicians routinely use thromboprophylaxis in high-risk surgeries. Less than half of the hospitals had guidelines on VT prophylaxis, and majority agreed that we should have Asian guidelines. Next. In 2017, the Asian VTE guidelines updated recommendations for the prevention of venous thromboembolisms. Next. It was recommended that Asians at risk of VTE should be considered for VTE prophylaxis. Formal hospital VTE protocol for risk assessment and prophylaxis should be established. Balancing VTE risk versus bleeding complications in an individual patient is recommended, and appropriate methods of thromboprophylaxis should be applied. Next. Patients with low VTE risk, no prophylaxis is needed. Patients with high VTE risk and high bleeding risk, mechanical prophylaxis is recommended. Patients with high VTE risk and low bleeding risk, pharmacological plus minus mechanical prophylaxis is recommended. To conclude, ladies and gentlemen, a subgroup of patients are at high risk for VTE and may benefit from thromboprophylaxis. Risk assessment should be performed at admission and before hospital discharge. Evaluate individual risk and start prophylaxis in the appropriate patient with high VTE risk. And finally, validated risk scores and guideline recommendations are available to aid in decision-making. Next. And with that, I thank you for your attention.
Thank you, Dr. Pantep, for the great presentation. I would like to introduce you to our final speaker, Dr. Christopher Ward from Australia. Dr. Christopher Ward is Professor of Medicine at the Northern Clinical School at the University of Sydney in Australia. He oversees the thrombosis and anti-coagulation clinics at Royal North Shore Hospital and supervises outpatient management of venous thrombosis. Over to you, Dr. Ward.
Chris, I believe you're on mute. I am too. Thank you, Jameela. In this section, I'm going to cover some special populations, ones where we have less evidence for thromboprophylaxis, and also outline some of the problems we've had in implementing the risk assessment that Pantep's outlined. All right. So in this, sorry, we'll go backwards. Here we are. A lot of our trial evidence comes from hospitalized patients, particularly elderly patients and quite complex ones. And the broader range of patients that we see may not be adequately reflected in this. And we're dealing with a bit of a disparity between the orthopedic trials, where we have good evidence with asymptomatic clots, but our surgical practice has clearly diverged since then. And we know there are subsets who are at high risk, but we sometimes struggle to identify these. And examples in the field of total hip and total knee replacement, really the modern practice with surgery, very early mobilization, improved technique, we can see over the last 20 years that the actual rates, particularly of proximal DVT and P, have come down. But at the same time, we've got other groups with unmet needs emerging, and patients with cancer that I'll cover, and other cases of patients where there's prothrombotic therapies. So let's talk about some of these patient groups. The first one I want to mention is thromboprophylaxis in pregnancy. Now, pregnancy is clearly a prothrombotic state. It has to be for the safe delivery of a baby in the placenta. And around 10 years ago in Australia, a set of expert hematologists and obstetricians came together to develop recommendations for VT prophylaxis. But they commented throughout this document that really there's a major lack of high-level evidence, and most of this was opinion. And as a result, there was quite a lot of dispute locally about whether to take up these recommendations, particularly after emergency cesareans. We know that pregnant patients who've previously had a VT must be at high risk, but are these all the same? And should we treat those with a provoked or postoperative clot differently from those with a hormonal or unknown trigger? How do we deal with very minor clots, superficial thrombophlebitis, and do any thrombophilias really change the outcome and the risk? This becomes even more complicated where we have family histories of VTE, often without a documented thrombophilia. And in cesarean section, is there a difference between emergency or an elective procedure? And we have to bear in mind the costs of antenatal prophylaxis in pregnancy. Many months of subcut injections with local complications, and patient tolerance becomes an issue. And certainly in our hospitals, women on Cloxane are routinely induced to allow for the possibility of epidural anesthetic. So moving on from the initial documents, we now have a variety of local advice. This is an example from South Australia. In Australia, each state tends to develop its own documents. And you can see a flowchart on the right that illustrates some of the thinking that goes into this process. And I'll just summarize the key points. If you have a woman who's pregnant with a history of thrombosis and she is on long-term therapy, she remains on therapy throughout. Similarly, more than 2 prior events, they would remain on therapy. But once you cut back to one event, it becomes a more complex decision based on whether this event was unprovoked, estrogen-related, or transient. And in the fine print below, they comment that really these decisions should be made with a hematologist or obstetric physician because there are quite a lot of factors to consider. Another group where we have a lack of evidence are the patients with lower limb injury, often sort of ankle fractures, people having complex foot or ankle surgery, and they may be immobilized for a great period of time, many weeks. And anecdotally, we often see clots in these patients, and they haven't been addressed really in large-scale trials. So DVTs appear to be common, but we seem to be lacking clear guidelines to manage these patients. We do have the Cochrane Database recently updated the available data that we do have, and there's a wide variation in DVT incidence after leg injury, between 4 and 40%, but this is often based on asymptomatic clots. The symptomatic DVT rate is probably around 2 to 5%. And a recent review by Horner et al. Looked at the evidence to date. Prophylactic low molecular weight or fondaparinux can reduce the odds of VTE, but unfortunately there's no evidence to support the use of DOACs in this population, where ongoing use for many weeks would be more palatable if it was an oral agent. They suggest stratifying patients, but there isn't any agreement in which risk assessment model to use. And the VTE risk likely applies to people who are in temporary mobilization, such as moon boots. The optimal duration is unknown. It's often 4 to 6 weeks. Moving on, I'll just briefly mention COVID patients. Heng has covered some of this, so I'll move through fairly quickly. But we're having to address the prothrombotic risk of COVID and also what to do with patients that are already on anticoagulation. There was limited evidence before the randomized control trials that low molecular weight may be beneficial. And in general, the guidelines in Australia recommended that we continue therapy throughout, but pointed out the difficulties of warfarin monitoring if someone was COVID positive and limiting their exposure to healthcare facilities. There's a strong association with venous thrombosis and arterial thrombosis in COVID, and prophylactic heparin's often used, but the randomized trials didn't demonstrate a benefit in critically ill. In non-critically ill, there may be some benefits, but we clearly have an increased bleeding risk, and we're waiting for some further trials to come out, particularly the Freedom COVID, looking at 2 ranges of low molecular weight heparin versus apixaban. Again, just to briefly mention the trial data that came out, the 3 prospective trials, they were halted for 2 distinct reasons. Firstly, futility in critical care patients with excessive bleeding, and also for superiority in the moderately ill patients. So it's clearly a complex matter that we have to look into further. And what's interesting, despite evidence of platelet activation in COVID patients, is the addition of antiplatelet therapy was of no benefit. So the recommendations from the American NIH as of late May for patients without an evidence of VTE and out of hospital, they recommended against routine prophylaxis also post-discharge, and in hospital patients to use heparins over oral anticoagulants. Therapeutic heparins in patients on low flow oxygen and high D dimers, prophylactic for ICU patients. But we're often given questions like this: what do we do with a patient with COVID being managed out of hospital who's had a prior clot? We have the option in our country of keeping these people or restarting low-dose DOACs, but we don't really have evidence for this. And I guess my practice for someone like this has been to anticoagulate them until their symptoms have settled. What about cancer therapy? Now, cancer clearly is a major risk factor for thrombosis, but this has proved to be extraordinarily difficult to come up with consistent policies that can be applied, partly due to the heterogeneity of patients and their therapies. Just some of the reasons why this remains a challenge: we have many scoring systems that have been proposed, and they may not match up well with a given patient. We're seeing increased survival of patients with metastatic disease and multiple cancers at the same time. And we really don't have good evidence to factor these patients in. They may not have been included in the trials. Many of our newer therapies, including in hematology, have prothrombotic risks. The use of the IMiDs in myeloma for one, the estrogen antagonists for prolonged use many years in patients after breast cancer, and antiogenic therapies. All of these will increase the risk of thrombosis. Now, inpatients are typically on high-intensity therapy, but they're often cytopenic. In our hematology service, we'll continue standard dose prophylaxis down to a platelet count of 20, but not every unit would agree with this. Once we move to outpatient and home-based therapies, which are the majority of chemotherapy, ideally would have oral agents, and some patients are resistant to the use of low molecular weights. There's emerging evidence for the use of DOACs, but drug interactions can be problematic. A recent update again from the Cochrane Database has looked at some further additions of randomized controlled trials, including some DOAC trials. And these are primarily in patients with locally advanced or metastatic cancer. For the DOACs, we now have some evidence that apixaban, rivaroxaban may decrease symptomatic VTE rates, although there's low certainty. And this is a price to pay in terms of higher major bleeding rates with moderate certainty. And those studies have some reasonable numbers now, over 1,500 patients. We have better data on low molecular weight heparins, where we have high certainty of a reduction in VTE, but also a price to pay in terms of major bleeding with a similar relative risk ratio. And in myeloma, again, a hematological disease with a particular increase in clotting risk, low molecular weight was superior to warfarin and aspirin. But how do we pick which cancer patients to give prophylaxis? The guidelines to date generally don't recommend primary prophylaxis for all cancer patients receiving outpatient chemotherapy. Their risk is not high enough, and the risk of complications is clearly too high. For risk stratification, the Caprini Score is the most widely used, and there have been many publications looking at this, including modifications, but it has low sensitivity. At least half of the cancer-associated thromboses described have occurred in patients with low scores, so using that solely as an instrument may not be adequate. We have two recent randomized control studies of DOACs, the Cassini study looking at rivaroxaban and the AVERT study with apixaban, and their target was patients with a Caprini scores over than 2. There was a reduction in VT on treatment, but also an increase in major bleeding. There are always issues with these trials, including the use of routine screening for clots at trial entry. And in the Cassini trial in particular, many patients were found to have incidental DVTs and therefore excluded. So although there's recommendations for improved scores, including modifications to the Caprini score, we still need some external validation. It's important to bear in mind that if a Caprini cutoff of greater than 2 is used, that applies to around about 47 patients, and that it probably is too high. Our international guidelines do suggest primary prophylaxis where Caprini scores are high, but also focusing on patients with high risk primary cancers, such as pancreatic. And targeting this may improve our outcomes. I want to briefly talk about some of the barriers to implementing VTE prevention with some examples from the Australian experience. We have problems with the usual suspects. Our health systems are often not integrated. We don't have people designated to take leadership roles, particularly at the nursing level. And often the responsibility for implementing these scores falls to the most junior and the most busy staff. The risk scores, as you've seen, are quite complex and take time. And although electronic medical records should make it easier, in practice, the number of steps required for a junior doctor to admit someone and get their medication sorted out is phenomenal. And adding another set of things to do is not always possible. And we also have issues as patients move between facilities. And in many subsets of patients, including hip fracture, cancer surgery, we're really lacking evidence to support an oral anticoagulant option, which should be more palatable. I'm just going to mention briefly something that we went through in Australia. I was part of this, representing the College of Physicians. We developed the Multi-Disciplinary Panel in the late 2000s, and the idea was that we'd look at all the data for hospitalized patients, prevention, and each of those studies would be reanalyzed by our own methodologists. And the data presented transparently along with the recommendations. And this seemed to be a good idea, and for a few years it ran. It was published in 2009. But in 2012, this was fairly suddenly abandoned, and a few years later, the guidelines were rescinded under pressure from different craft groups who really didn't feel that these guidelines were applicable to their work. So who would be opposed to VTE guidelines? And I'll just mention some of the arguments against this because this was quite instructive. We had a set of people, particularly from surgical and anesthetic backgrounds, who took issue with the whole process, and their objections were primarily on the structure and design of those randomized controlled trials. They believe, and I'm not endorsing these views at all, that serious and fatal events are extremely rare in modern clinical practice. They believe the asymptomatic events that were seen were not significant and never lead to serious VTE. And therefore, they concluded that routine prophylaxis with heparins was causing more harm than benefit, and also called into question the trial designs and bias in any trials reported by pharma. Having said that, we've moved back towards a different process now, and this is coming through a different direction, that of hospital quality standards, because clearly people in charge of our health system have realized that VTE is a significant problem and it is preventable. So we now have amongst our set of quality standards, VTE prevention has been recently included. There are no national mandated strategies, but this set of standards does apply to both public and private hospitals, so it is a way forward. And we now have, again, without mandating, I'll just go to the next slide, we have a clinical care standard that outlines what each health system has to do. Clearly, it would be better if there was a consistent approach nationally, but here are the steps that our major health systems have to undertake to both assess and document VTE risk, develop a plan, partner with the patients, and use appropriate methods. And I think this is the way forward. So I'm going to finish there, and I look forward to the Q&A. Thank you.
Thank you, Dr. Ward. That was very interesting. I'd like to thank all speakers for sharing such insightful updates and information. I have learned a lot, and I'm sure you have too. Now we'd like to turn it over to you, our participants today, for today's interactive question and answer session. We have about 30 minutes for questions, so we invite you to submit your questions using the question and answer box on the screen. I have an announcement to make. Due to unforeseen circumstances, Dr. Huyu is unable to join us today as an expert panelist, and he extends his apologies. So our panelists for today's Q&A will include our three aforementioned speakers and one expert panelist who will answer your question and also share VTE risk assessment policies in their countries. First, I would like to introduce Dr. Eriko Morishita. She's our expert panelist. Yep. Dr. Eriko is a professor in the Department of Clinical Laboratory at Kanazawa University Hospital in Japan, and she is a member of the World Thrombosis Day Steering Committee. Without further ado, it'll be Dr. Eriko. The floor is yours.
Yeah, thank you for the introduction, Jameela. I'd like to talk briefly about VTE risk assessment in Japan. Next slide, please. According to nationwide Japan Venous Thromboembolism Treatment Registry observational study in 2014, the most common risk factor for VTE was cancer, followed by immobilization and recent surgery. In other words, about 20% of VTE were surgery-related onset VTE, and 80% were non-surgery-related VTE. Therefore, it's important to conduct a risk assessment at the time of admission and take appropriate prophylaxis, even for non-operative medical inpatients. Next slide, please. Yeah. In 2018, the Japanese Circulation Society published the guidelines for diagnosis, treatment, and prevention of pulmonary thromboembolism and deep vein thrombosis, JCS 2017. The tables on this slide were prepared for VTE risk assessment and prophylaxis in non-operative inpatients with reference to the JCS 2017 guidelines. As shown in the table on the left, malignancy and respiratory failure are classified as moderate risk, while congestive heart failure and paralytic stroke are classified as high risk. As shown in the table on the right, prophylaxis is recommended for each risk level. The Japanese guideline recommends a greater emphasis on mechanical thromboprophylaxis rather than pharmacological prophylaxis with anticoagulation therapy. In fact, the incidence of VTE has been decreasing in Japan with the spread of mechanical prophylaxis. For hospitalized patients at a moderate risk of thrombosis, mechanical thromboprophylaxis with intermittent pneumonic compression IPC or graduated compression stockings GCS is recommended. For patients at a high risk of thrombosis, anticoagulant thromboprophylaxis or IPC is recommended. However, for the patients who are bleeding or at high risk for major bleeding, the guidelines suggest mechanical thromboprophylaxis. Next slide, please. Next slide shows the VT risk assessment and the prophylaxis in operative inpatients. As the table on the left shows, the risk levels of general surgical and non-orthopedic patients are classified into 4 levels: low, intermediate, high, and highest risk. A separate guidelines has been developed for orthopedic surgery. Major surgery for cancer patients over age 40 is classified as high risk, and the major surgery with a history of VT or thrombophilia is classified as highest risk. The risk level of each surgery or disease is evaluated comprehensively, taking into account the additional risk factors shown in table on the right. Depending on the additional risk treatment and condition, the implementation of a higher level of prophylaxis may be considered. Depending on the final VT risk level determined, the prophylaxis just indicated is recommended, but the risk of bleeding should also be considered. In Japan, low-dose unfractionated heparin is usually used for anticoagulation in the treatment and the prevention of VTE. Enoxaparin, a low molecular weight heparin, is approved for VT prophylaxis only after lower extremity orthopedic surgery and abdominal surgery. Fondaparinux and etixaban are also approved for VT prophylaxis only after lower extremity orthopedic surgery and abdominal surgery and VT treatment. And finally, I will discuss the issues in Japan. And the biggest issue is that low molecular weight heparin is not available as VT treatment. We are going to request the government to allow the use of it for VT prophylaxis and treatment in all cases. The next point is that cancer-related thrombosis has been increasing due to advances in new cancer drugs such as targeted therapy, IMiDs. So a cancer-specific risk assessment may be necessary. Thank you for your attention.
Thank you, Dr. Rico, for sharing your VTE risk assessment in your country. And I would like to share ours too in my country of Malaysia. So I'll just quickly go to the slides. Next, please. Okay, VTE, we don't have much data on VTE rates in Malaysia. As what Dr. Lee has said, yeah, no doubt our rates in the Southeast Asia is low, but it's slowly increasing. We know that in Europe, there's about 100, the incidence of VTE is 100 per 10,000 hospitalized patients. In Singapore, that has come up to 73 in 2006. What about Malaysia? Next slide. We don't have data, but I had done a study in our own hospital, which is Ampang Hospital. It is a 600-bedded hospital, multidisciplinary with a big hematology service. And the rates for per 10,000 hospitalized patients is around 25. So it is there, yeah, not as common as in Europe, as in the West, but it is, I think it is rising too. And this is the confidential inquiry of maternal death report, Malaysian report in 2018. And as you can see here, the maternal deaths due to PE or pulmonary embolism is increasing, and the specific MMR per 100,000 live births is 4.7 in 2006. Slowly increasing. Next slide. So in 2013, we sat down and developed a national VTE CPG, and this is it, the front cover. Next slide. This is the quick guide, and as you can see, and next slide. So we have a quick guide to medical and surgical patients, the risk factors. Next slide. And also antenatal risk assessment and postnatal risk assessment. Next slide. Next slide. Next slide, please. Yeah. Next slide. And we also have an apps which we have done. Yeah. And we're updating that apps. Yeah. And in 2016, we also did a training, yeah, on the pathways. So this is for the medical and surgical patients, and this is for pregnancy and puerperal. And as you can see, yeah, all women should have a documented thromboembolism risk assessment, and we have divided that into 4 groups. Next slide. And this is the algorithm for, yeah, for antenatal and postnatal. So I did an audit in our hospital, next slide, yeah, to look at the proportion of patients getting prophylaxis when it is indicated. 1 month audit. And as you can see here, obstetrics did the best, 100% of patients were getting prophylaxis, followed by surgical, yeah, orthopedics, ICU, medical patients, ICU surgical as high as 50%, and general internal medicine about 40%. So I'm happy to see that. Yeah. So hopefully our clinicians are practicing thromboprophylaxis, VTE assessment and thromboprophylaxis. Okay. So without further ado, let's get started with the Q&A session. So remember to submit your questions to your panel by using the question and answer box on your screen. So let's look at the first question. I think, although the question has been answered, yeah, but let's see. 5, answer 2. I think the first question was to Dr. Leela Heng. How about the result of Garfield registry in Asian population? I know you have answered it, maybe you can answer it to the, you know.
Yeah. Okay, the Garfield, I think, showed still cancer as a risk factor more prevalent in Asian than the rest of the world. And this is published by Pantep. Pantep, would you like to comment?
Yeah, I can take this question. Garfield VTE is a global perspective non-interventional study of the real-world treatment practice. And in this study, 1,822 patients, or 17%, were Asian, and it was found that Asian patients have different risk profiles than the rest of the world. Asian patients tend to have more female and non-smokers and lower BMI. And as mentioned by Lai Heng, Asian patients tend to have more cancer than rest of the world, 19% versus 8%. So it's more than 2 times higher than the rest of the world that Asian patients have cancer. And also treatment patterns are different. And also Asian patient has a higher risk of mortality compared to the rest of the world.
Okay,
thank you.
Thank you. Thank you, Dr. Pantep. And the next question is, in low-income country that has difficulty in getting imaging to diagnose VTE, we just rely on clinical symptoms and physician judgment. And will you see its accuracy? Yeah, I think you need to have.
I answered that question.
Yeah, you answered
Jameela, I answered that question. Yeah.
Okay.
So just to emphasize that the signs and symptoms of DVT and PE is very elusive. It's totally non-specific. You know, so we need to confirm the diagnosis with imaging. And besides, the treatment for VTE is anti-coagulation, and that carries a small bleeding risk in itself, right? So in delivering a treatment that has got some risk, we had better be sure that the diagnosis is correct in the first place. That's why I think we need to confirm the DVT and PE and not just rely on signs and symptoms alone, because signs and symptoms can mean many other diagnoses besides DVT. Yeah, any other comments, Chris?
Especially in pregnancy as well, right? In pregnancy as well, yeah. So non-specific.
Yes.
Yeah.
It's very non-specific.
Here's another question. May I ask about the pathology behind factor 7 deficient coagulopathy associated with the risk of thrombosis? How could I take care about the bleeding management in the background risk of thrombosis? I don't quite get that. Dr. Watt, you want to answer that?
No, I'm not really familiar with no. Although we see some 7 deficient patients, I haven't come across any with a higher risk of thrombosis. Yeah. That must be a specific setting that our person's referring to. Has anyone else come across that?
I have not come across a 7 deficient patient with thrombosis, but I think in the same arcing principle, you know, like hemophilia A patients, especially the elderly hemophilia A patients with mild hemophilia, when they go for high-risk procedures or when they got other risk factors, I mean, they do get thrombosis, thrombotic problems like ischemic heart, stroke, if they have got other arterial thrombosis risk factors. And we do have patients going for surgery if they are over-transfused, over-corrected. And if the surgery by itself carries a thrombotic risk, it's not unreasonable to think that thrombosis can occur. You know, I have seen DVT occurring in hemophilia A patients as well. So I would think that for factor 7 deficiency, as in hemophilia patients, we should risk assess case-by-case basis, you know, the bleeding phenotype and other risk factors for thrombosis. And then we make a judgment call on a case-by-case basis based on the risk assessment. So it is not possible to give an overarching one-liner answer to this question, because it's really very dependent, you know, on the individual thrombotic and bleeding risk, as well as a situation. It's very situational.
Yeah, I agree with Heng, and you know, patients with factor deficiency tend to have a bleeding tendency than thrombosis risk, unless this patient is overtreated. For example, given a higher dose of recombinant 7A might be prone to thrombosis, but otherwise, this patient tend to have more bleeding.
As a question to Dr. Ward, you said that VTE prevention methods in orthopedic surgery are in flux. Hence, the recent international guidelines endorsing aspirin as the preferred pharmacological agent in patients at standard risk. How do we define standard risk in this patient?
Look, I think that's very difficult, and there's been a push, particularly out of North America, to default back to aspirin as a sort of easy option perceived with little bleeding risk. But almost all the patients I'm aware of undertaking, particularly hip and knee surgery, already have risk factors. They're often elderly, they're often overweight, and we know in other settings that aspirin is clearly inferior to the DOACs and low molecular weight heparin when it comes to clot prevention elsewhere. Now, some of the trials that have been used for these recommendations did actually do a mix. I'm aware of 1 or 2 trials where patients had a short period of DOACs post-surgery and then transitioned to aspirin. So I think it's proving quite difficult to sort of really work out how the surgeons make their selection. And I know in our system in Australia, it's very much up to the individual surgeons. And many of the ones that I work with will still use DOACs or low molecular weight heparins. Others have gone the route of aspirin, but I would propose that standard risk means an absence of the risk factors that we're aware of, including the ones I've mentioned. And particularly for folk who are going to be slow to mobilize, I'd be concerned about that. But again, this will evolve. And what I think we'll see in the next year or two is the results of a new class of interesting anticoagulants, the factor 11 inhibitors, where perhaps we can have another go at this topic and look to see if we can improve the clot prevention versus bleeding risks.
What about the other panel? Do you have, what are your views about using aspirin in post-orthopedic surgery? I mean, I know I see a lot of orthopedic surgeons are moving away from the standard low molecular heparin to using aspirin, even with those with higher risk, you know. So,
well, as mentioned in my talk about orthopedic surgery now, because with the technique has changed, the patient just stay, you know, after total knee replacement, they can come home in the next day instead of staying in the hospital for a week or two in the past. So I think the technique has changed a lot. And then if the patient doesn't have any additional risk factors other than surgery, I think aspirin might be okay for orthopedic surgery as a standard risk as asked by the audience.
Actually, I think it would be good, you know, if we can review these cases and get some data out to see the efficacy of aspirin in preventing VTE. You know, well, it will have all the limitations of a real-world study, you know, or retrospective study, but it will give us some idea, you know, as to whether how effective this strategy is.
true. We need more studies. Question to Dr. Ward. What's your approach to thromboprophylaxis in women with abortion and a history of VTE? Do you differentiate between early and late abortion and between spontaneous, medically induced and surgically induced abortion?
Yeah, look, that's a complex question too. I guess if a woman with a prior history of VTE is known to be pregnant, I'm certainly in favor of starting prophylaxis early. And with the exception of women where the prior clot was clearly linked to surgery or say, broken leg. So if you started early, then I'd assume by the time they miscarried that they'd already be on prophylaxis, and I don't think you'd need to extend that for much longer. If it is a surgical or medical abortion, again, we don't have a lot of data there. So it depends on whether someone's been started. Most of these women are young and fairly healthy. So there probably isn't a role for extended prophylaxis if it hasn't already been instituted. Heng, what do you think?
I think is the question directed at prophylaxis during pregnancy, during a subsequent pregnancy for these patients? If it
I
is,
think it's more about the miscarriage, dealing with either miscarriage or abortion, and whether thromboprophylaxis is required then.
Yeah.
Then, oh, I see. Then it depends on whether the patient had previous history and other risk factors. I would not prophylax just based on the history, just based on the woman going for an abortion. Unless there's a strong, I'll just treat it like any other surgical procedure, whether there's a past personal history, family history, or other risk factors, you know, accentuating the risk of thrombosis during that procedure.
Yeah, but one thing to keep in mind that in patients with a history of VTE and spontaneous abortion, we might have to consider whether this patient have antiphospholipid syndrome or not.
Yeah, right. But if the patient has developed a DVT associated with previous miscarriages, you know, and even though they do not have APS, in subsequent pregnancy, I would prophylax them because it's hormone related.
And look, the other group that's interesting in that setting are the women undergoing IVF. And again, we have better access to that in Australia, clearly, but some of the ovarian hyperstimulation, quite high risks of thrombosis, and interestingly, upper limb thrombosis. And we're often called to advise on what type of prophylaxis would we give and how long during those cycles. So that's another twist as you start to intervene with hormonal levels.
Question to Dr. Eriko.
Okay.
In Japan, how accurate is it to stratify just based on surgery type and age? Can you share more on that?
Okay, yeah. We evaluate the additional risk factors for VTE. For example, we could additional risk factors are obesity, hormonal therapy, versus veins, and moderate risk factors are congestive heart failure, respiratory failure, chemotherapy, severe infection, and strong risk factors are thrombophilia, or paraplegia. So the risk levels is evaluated comprehensively using the additional risk factors.
Another question to Dr. Ward. You said that VTE prevention methods in orthopedic surgery are no, I think that's the same question.
Yeah, we answered.
No, we've done that one.
Yeah. Okay, another question. Could you share your experiences in pediatric thrombosis prevention? Who's the pediatrician here? Dr. Pantep, you take that? I think pediatric cases are very low risk of thrombosis, right? So it'll depend on other risk factors. Is the child very obese? And
usually cancer and complex cardiac procedures, isn't it?
Yeah.
You've got to do a lot to a child to cause a thrombosis, and it's certainly not something you'd routinely undertake for hospitalized children.
I think a lot of line thrombosis, though, the thrombosis in children are mainly the line thrombosis. Not in the position to comment.
they usually take it off, remove the line. Can you share more about the latest recommendation for anticoagulation in COVID patient in Asia?
Okay, so as I mentioned earlier, you know that for our COVID patients in ICU, we follow the standard ICU Vt Prophylaxis protocol, right? We actually do not give them higher doses than what is required in the standard dose for prophylaxis. That's despite the earlier calls, from Europe when they reported very high figures. But actually, subsequently, as the pandemic moves on and you look at the systematic review, the rate of DVT even in the West is not as high as it was first reported, like 60%, that kind of thing, right? So, and we look at our own patients, our DVT rates are really very low. So we will look at other risk factors, whether there are other risk factors to warrant a prophylaxis. COVID-19 by itself, and not critically ill and not terribly immobile, we actually don't give prophylaxis for the sole reason of COVID-19 infection, right? That I must add that sometimes it's difficult in the pandemic situation where your contact with patient is limited, to get a proper risk profile history, whether they got past history, family history, or other risk factors. And that I find that often may be lacking on the ground because they're struggling with huge patient load. And on top of that, with all the infectious control protocols, fully gowned, and not the best situation, to work under.
In our hospital, and all hospitalized COVID patients with severe pneumonia, we receive prophylactic dose thromboprophylaxis with longer heparin if the patient do not have contraindication or have breathing tendency. The guidelines, mostly are derived from Caucasian patients, and those patients have higher risk of thrombosis than Asian patients. So whether or not we need to use a full therapeutic dose for a non-ICU patient or not, I think we have to look at breathing complications from higher dose anticoagulant too.
Yes, for our patients with pneumonia, we risk assess and we do give them a prophylactic dose as well, but not for the not so sick patients. We don't prophylax just because they have COVID-19.
I'd like to take this next question. Do you know if there is an international registry of hospital thromboprophylaxis in which Latin American countries can participate?
I'm not aware.
Not at the moment.
Not at the moment,
This has been done in the past, about 10 years
Yeah.
ago, or perhaps more. There
Mhm.
was a study looking at different countries around the world and their rates of prophylaxis, and that was useful as a trigger to try and improve processes. But I don't think it's been done again since.
Yeah, well, the INDOS study was done several years ago. Yeah, and the Garfield VTE registry also involved Latin American countries.
I think we can only take one last question. Yeah. Can each panelist share what he or she would like to see for VTE prevention in their country 5 years from now? What is their ideal vision?
Chris, you go first.
Yeah, look, I'd like to see an extension of what our hospitals are doing with the standard, so that every hospital-acquired VTE becomes reportable and is measured. And that's across the public and the private, because in the surgical setting, the patients often move from 1, 2, or 3 facilities. And the surgeons aren't even aware that their patients had a clot in some cases. So I think if we track our events, then we'll know how our strategies are working. And to me, that's the single biggest thing, to have a continual review of our performance, and we can address what's working and what isn't.
So
Well, my
I think I
turn.
would like to say that every patient should have VTE risk assessment and also with breathing risk assessment and give appropriate prophylaxis. And one thing to keep in mind that VTE is preventable.
Yeah. So I share Pantep's sentiment. I share Pantep's sentiment that we should work into our pathways, especially now that the case notes are all going electronic. You know that VTE and bleeding assessment should be treated as part of pain, like pain score. You know, the part of the parameters that should be entered into your case notes. And with the risk assessment, then people are made aware, you know, of the need to prophylax.
Dr. Erica?
Yeah, first, we will be able to use low molecular weight heparin, and then, yeah, it's important. And then we should make specific cancer treatment and cancer associated to the thrombophilia prophylaxis. Yeah.
I think for Malaysia, I think we need more data. So it'd be good if we have a national VTE registry. And also like what Dr. Pantep and Dr. Lee said, maybe perhaps in every hospital, we should have just like a pain score. You know, all the hospitals are now all IT based. So we should just pop up for every patient that's admitted to the hospital. You know, we have a pop up for all doctors or, you know, even nurses to fill in the VTE risk assessment. I hope that should be a reality. Yeah. And for Malaysia, of course, we need more data. We need all this big data they've been talking about, but I think we don't have it's a lot of budget, and I hope that our country will be more sorted out in the future. Yeah.
Actually, we all need more data, you know, especially more recent data, because the older data on the risk, you know, of like surgeries, and they have all changed because the surgical techniques have changed, anesthetic techniques have changed, right? So I think, yeah, we do need more data, yeah, more updated data.
Yeah. I think that is all the time we have for today. Thank you so much for all your questions. You will receive a follow-up email in the coming days that will contain a recording from today's discussion. Please join me in thanking today's presenters for their important presentations and insights. Give them a clap. I've really enjoyed this discussion, really, and I hope you have too. This webinar was hosted by the World Thrombosis Day campaign, and we invite you to participate in and support World Thrombosis Day, which is coming up on October 13th. Yeah. Get involved by planning or participating in a World Thrombosis Day activity in your community. Share information on social media and sign up for global digital events hosted by campaign headquarters. For more information, please visit www.worldthrombosisday.org. Thank you once again for participating in today's webinar. Have a great day.